Do I need the microphone? Or yes. People say yes. That's it. My first, May told me I would be talking to 20 people. So I am convinced that many of you went to the wrong room. And I won't be offended if you want to just like, oh man, you know, I'm upstairs in object relations. I get it. What I do want to ask this group is how many of you are therapists of some sort? Many. How many of you are educators? Many. How many of you are parents or grandparents of people that you're worried about? And finally, are there any kids here who are anxious, teenagers? If you're embarrassed to raise your hand, that's okay. So, because we have such a mixed group, I thought that I would just give a little overview about anxiety in childhood. And I'm sure people will respond to different things. First of all, my funding from the National Institute of Mental Health and Brain and Behavior Foundation. Don't worry about it. Okay. So I wanted to start out with this photo. Does anyone know who this is? I know some of you do. This is Charles Darwin, and a lot of the things I'm going to be telling you about today might be kind of a downer about pediatric anxiety disorders, but I want us to think about anxiety in a broader context. We'll go through the epidemiology a little bit, and this is a really prevalent problem. This is the most common set of psychiatric disorders in the world, but certainly in the US, we know. About a third of the population has a DSM-4 or 5 anxiety disorder. So what does that tell us? That tells us that there's something adaptive about anxiety. I spend a certain portion of my life with anxious kids and their parents, and parents feel very guilty. There is a genetic component. There is an epigenetic rearing component. But just remember, it's not all bad. This would have been selected out years ago if there weren't elements of the anxiety genome and things that it brings us that are actually adaptive. So I'm saying that mostly to parents and educators. I think it's important that we remember that. Okay, this is epidemiology. These are the most common mental disorders in the US. This is the National Comorbidities Survey data. About a third, little under a third, of people in the US suffer from an anxiety disorder. 12-month lifetime prevalence, 12-month prevalence, about 18%. Anxiety disorders impart a huge impairment in role functioning. As part of the National Comorbidities Survey, they looked at costs of anxiety disorders, and shockingly, this includes treatment, lost work, impairment in functioning, and they came up with $42 billion a year. That's not good. This is multiple visits to ERs. This is multiple medical workups. So that's really important. Still, despite all of this focus on psychiatric education, on making the public aware about psychiatric disorders and that treatment is available, Ron Kessler found that the index time between development of an anxiety disorder and first contact with any sort of psychotherapy or psychiatric professional is about 10 years. So we have a lot of work to do. Okay, just a little bit about nosology and psychiatry. We have switched around our nosological system. We now have the DSM-5 as opposed to the DSM-4. So what does that mean? So these are the anxiety disorders that are currently characterized. Separation anxiety disorder was bumped up from disorders of childhood and adolescence to apply across the lifespan. We think this is a good change. Panic disorder remains itself. Agoraphobia now can be appropriately diagnosed across the spectrum of psychiatric disorders and as an independent anxiety disorder. It used to be that you had to have panic to get agoraphobia. Turns out lots of people have agoraphobia. Maybe they have other illnesses too. Okay, generalized anxiety disorder, social phobia, specific phobias, the most common mental disorder there is. And of course, we've switched around our nosologies. So we no longer consider PTSD an anxiety disorder in the DSM-5. Some of us disagree with this. And OCD, which I think everybody is pleased to see go. Okay, so let's think about development and anxiety. So first of all, kids are worried. It's normal to be worried. There is no one in this room, there is no one alive who's never been worried or anxious. These are normal experiences. And if you go across the lifespan, you'll see sort of different focus of anxiety. So little babies are scared of loud noises or being startled. And of course, everyone knows about stranger anxiety at 8 months. Once they're talking and walking and they're toddlers, they're more scared of like creatures under the bed or being in the dark, or what we would call normal separation anxiety, because separation anxiety, though it is a DSM disorder, is actually adaptive in earlier phases of life, like when you're a toddler. Once they're in school, that's when we start seeing kids being frightened of like thunderstorms, getting hurt. And of course, adolescents are nervous about everything: social competence, school performance, sex, sexual identity, health. Okay, the younger you go across the lifespan, the harder it is to differentiate these DSM disorders. We've known that as child psychiatrists, we've known this forever. None of the nosological systems that we have ever had in psychiatry have really ever applied to kids, especially the little ones. And then as they hit sort of late school age, early adolescence, you can start to differentiate a bit better. What you more see is just they're very nervous people. That's the kind of thing you see. There are no good cross-national studies, or there is no national comorbidity survey in kids. We have tiny little epidemiological studies that are focused in small locations. That's because they don't fund these things. So according to where they've looked, and methods, because methods are, that's the devil in the details, it ranges from 6 to 20% of kids who have it. We think it's more 20. So in terms of disorders, again, we're not going to label any toddler with any specific disorder. But by elementary school, we certainly see specific phobias, GAD. This used to be called over-anxious disorder, social anxiety disorder. And here, sort of in early elementary school, kindergarten, you see kids who are really, really shy. They really have trouble engaging socially. By late elementary school, that's when we would start to see sort of a diagnosable separation anxiety disorder. Now, these are just broad outlines. There are going to be differences, and certainly maybe you know a five-year-old who really has separation anxiety disorder, but it's sort of less common than a little bit older. And it's partly just what do we expect of our 8-year-olds. We expect our 8-year-olds to be able to go to school, sit in school all day, come home, not freak out. Maybe even consider going to sleepaway camp. They can't all do it. Agoraphobia starts to take hold in elementary school. And really, the panic disorder can present in sort of prepubertal ages. It's really a disorder of adolescence. And of course, panic disorder is its own world of pain with a huge connection to substance abuse and suicidality. So why do we care about anxiety disorders? They're so prevalent. We all know kids with them. It's because they're kind of damaging. Even if you don't meet full criteria for a DSM anxiety disorder in childhood, it can really hold you back, and that's the concern. These kids have a poor sense of competence. They are worried all the time, and it impairs their regular development. And it's been linked to sort of low school performance, difficulties both acquiring reading and math skills. And of course, that's a two-way street. If you have developmental reading or math disorder, it can make you very anxious about performing, and vice versa. If you're very anxious, I have a patient like this, 6 years old, it's hard to sit down and try to think about math. So there's lots of risk factors, genetic, certainly these things. There is, though we don't have one anxiety gene, certainly we know these, the sensitivity to anxiety has a familial, heritable quality. There is an environmental risk factor, which we'll talk more about. Parents with anxiety disorders bring both of these risk factors to their kids. So these kids get a double dose. And you know, the way we think about genetics, certainly within psychiatry, is there's a genetic vulnerability, and then if the person is in a vulnerable situation, say an anxiety-provoking environment, it'll hit them, whereas it won't hit everyone else in the same way. Essentially, and I'm going to say this a number of times, and I'm sure we'll wind up talking about this later, but really one of the biggest environmental risks from a familial perspective is parents who really have trouble coping with their kids' anxiety. And we see it, it looks all different ways, but you know, if it feels like a crisis to the parent that the kid isn't sleeping and is screaming, then it feels like a crisis to the kid. And of course, as parents, we don't want to be imparting that sense of urgency. So there's certainly a whole lot of work that's been done about attachment style. Attachment, I could give like a 3-month course in attachment. So if I get too detailed, just I'll stop. But basically, we have ways of coding attachment in toddlers, and there's a syndrome that was articulated first by some researchers at Harvard called behavioral inhibition to the unfamiliar. I hope some of you have heard of this sometime in your training. But basically, these are these extremely nervous. They started looking at 30 to 36 months old, so really little kids who just they freeze and are absolutely terrified if they're in a safe environment with a nice person that they don't know. So that's an atypical response. And this work was started by Joe Biederman, and he actually has a sample. He's a geneticist, and he was looking for sort of very high-risk kids. So he took kids of mothers with panic disorder, and then he included a bit later mothers with major depression. And he found a high concentration compared to sort of normals or unaffected kids of parents of this behavioral inhibition. And he's been following this sample for over 14 years. He hasn't published the most recent findings, but somewhere around 30% of the kids who he identified as having behavioral inhibition go on to develop agoraphobia and separation anxiety disorder. And they've been doing some work in developing animal models. I don't think we'll probably have time to talk about that unless people are interested. So what is it? So these kids are really, really shy. And they did a bunch of both genetic and environmental studies. And it looked as though in some of his earliest work in specific, where they were really looking at parenting style, it looked like parenting style made a huge difference in terms of the outcome of this group of behaviorally inhibited kids. So only 30% of them went on to have diagnosable anxiety disorders. The rest of them didn't. So it really could be ameliorated by parenting style. And they have all kind of little biological markers that they were able to track. Increased sympathetic tone, high heart rate, low heart rate variability. So then just a word about sort of adolescent conflicts and panic. As I said, we're sort of moving on through the developmental frame here. So sexual conflicts is a big deal, defining, number one, that you're allowed to have a sex life, or maybe you're not. Who are you interested in? Who are you? These are highly hot topics, particularly in adolescence. And, you know, on the blogosphere, people always talk about it. A lot of our anxious and panicking kids are really terrified to even think about it, but it's going on. So these are common conflicts in the adolescence that we see. With panic, another huge common conflict with these kids is just this really conflicted desire to be much more independent and autonomous of their parents, and yet they're really bonded to their parents. That's a huge conflict. Almost all patients with panic disorder, and this is from a study that was done, it was published in the American Journal of Psychiatry just last year by a group of Swiss investigators. Kosowski is the first author. Almost all patients with panic disorder started out with a childhood history of separation anxiety disorder. So, you know, ideally, we really want to try to intervene in childhood. This is one of our goals. Because, in fact, child and adolescent anxiety disorders actually predict fairly bad outcome if they're not treated. So there's a 2 to 3-fold increase in depression and anxiety disorders in adulthood. There are these chronic academic, family, and social impairments. There's a fairly high incidence of substance abuse in these kids, especially as these illnesses become chronic. There's any sort of group that you look at, whatever study, it's always around a 20% incidence of suicide. And of course, there's been a lot of work about the link between anxiety disorders in childhood and subsequent development of major depression. So if we're thinking about adolescence, and a lot of things could go wrong, right? Well, all of a sudden, they've got this fabulous new cognitive maturity. You hear them talking. Suddenly, they can do formal operations. They're thinking about ideas. They're not just thinking cause and effect. There's this huge societal and peer pressure to separate from their family, even if they don't really necessarily feel ready. There's a lot of pressure to define themselves individually, and that's linked to this pressure to separate, as opposed to their family. So it leads to, you know, the typical thing that you hear of these screaming fights between teenagers and their parents, which are bad. And of course, defining their sexual identity. So that's a big job while you're trying to go through the SATs and pass high school. You know, it's a lot for them to do. We are? Okay. So,
We have 10, 15 more minutes.
okay. So I thought I would spend a little bit of time talking about separation anxiety and attachment. These are my guinea pigs. As you see, they're really attached. And I like to show this picture because attachment and separation anxiety are really features of mammalian development. You know, if you think about reptiles, like the idea of a frog with her 20,000 tadpoles, the idea of attachment or separation anxiety is kind of absurd, right? But once we get to mammals, this is a piece of survival. And it just comes with being who we are. So what is it? So I'm partly talking about this because it's so important in child anxiety disorders, but it's also, the more we learn about it, the more we see that separation anxiety forms a backdrop to other anxiety disorders. So the idea is there's a central dyadic relationship. If you're looking at a grown-up, say, I run a separation anxiety disorder study or a separation anxiety study, and I mean, we have people who are in their 50s who certainly meet criteria. It's not their parents, but someone else has taken that place, often a spouse or a partner, a child. But in any case, that central dyadic relationship is necessary for this person to feel safe. So that's important. So as I said earlier, the whole idea of separation anxiety is adaptive when you're a little helpless infant. And this goes back to Bowlby and attachment. It would not be adaptive if we as parents abandoned our toddlers if a lion came. And similarly, you know, we as parents need to hear from them that they're miserable and that they need us. So it clearly promotes survival, and it's important. Of course, if it persists, and it can later in life, then sort of the idea of danger without this other dyadic person is really just a fantasy. You feel, you know, my 32-year-old separation anxious patient feels like she will not be able to breathe or function without her mother. That's actually not true. But the fantasy feels compelling. So what we have found, and it's, you know, this is researchers in Italy and at Western Psych in Pittsburgh, and we're doing this study, is that separation anxiety co-occurs across anxiety disorders and mood disorders. And as I said to you before, childhood separation anxiety disorder definitively has been shown to lead to panic disorder and other anxiety disorders in adulthood. So these are, I'm sort of emphasizing this because all of us need to pay attention to this in the kids that we run across. So why, okay? Definitely there's an inherited temperamental factor that is genetic. So these people have a lower threshold to become anxious and overwhelmed than other people. Difficult early bonding. So, I mean, the animal models are sort of instructive. They have created, there are these miserable mouse strains who are just born extremely anxious, and you know, they do all this sort of nervous grooming. You know, they've spent years creating these mouse models. But then what they've done in non-genetically bred anxious mice is they've selected for the most anxious parent-child or mother-pup pairs, and they've bred them, you know, the most anxious to the most anxious. So 25 generations later, because mice reproduce fairly quickly, they look just as anxious as the genetically bred mice. So that's instructive. So something about sort of parent-child behavior, and specifically mothering behavior in mice, and there's a primate model as well, really impart this experiential phenocopy. They look identical. And if you're interested in this, Myron Hofer has written about this a lot. So, you know, there are parenting patterns. It's easier to see in the animal models than in people, but we'll try to talk about it a little bit. So certainly very anxious parents. You know, if you're a therapist or an educator, I'm sure you've seen mothers where every little thing is an international disaster, and you really want to say, like, it's not. It's okay. Okay, she forgot her homework. Okay, it's all right. So, you know, that really lends this tenor of urgency to the whole household, and certainly these little anxious kids who are vulnerable. These very depressed parents can create, not on purpose, but a situation where kids just feel neglected, and it's very frightening. And in any case, no matter whether the family really has, whether parents have a psychiatric diagnosis or not, it's really the inability to tolerate their child's anxiety and kind of soothe them. You know, it's okay. The ambulance isn't for you. You don't have to worry about that now. And there are parents who just can't say those words, who really need to respond to every little worry. And those are things that raise anxiety levels, especially in young children. So what happens? So these kids feel incompetent, and like they can't develop sort of age-normative independence. Sleepovers get scary. School gets frightening. If your mom isn't there, it could be an emergency. What if there's an ambulance down the street? And in this way, you just see them fall off their age-normative developmental tasks.
I don't know what analogy.
I don't know. So, okay.
Do you want to introduce any dynamic understanding?
Well, a bit. I was just trying to do something very basic. So certainly kids don't feel like they're old enough or competent enough to manage their lives. They don't really feel like they can handle other relationships, and relationships take on this tone of, I'm incompetent, I need your help, I need you, I need you, I need you, it's a crisis. And of course, if you're a therapist, this is what your transference relationship is going to be like. And these are relationships that you see sort of repeated in parents, in the therapy relationship, in relationships with surrogates, teachers, doctors. But certainly if you're working dynamically, this is going to be where you're going to have to work. So of course you know this, that formative relationships have far-reaching consequences, and that they really influence kids' ability to internalize their sense of themselves and other and relationships with others. They influence their ability to soothe themselves, which is really what we're talking about here in pediatric anxiety disorders. And of course, tolerance of uncertainty. Life is full of uncertainty, you know, and high levels of affect and becoming more independent. So I just thought I would say, if people are interested in contributing, we are doing a study of kids with anxiety disorders and treating them in dynamic treatment. And if you're interested or if you have questions, write to me or call me. I think we should probably open it up.
Open up the questions.
What is the psychodynamic approach to deal with adolescent anxiety and developmental somatic form illness? So now that they're becoming underlying factor has been anxiety, and is there a sort of psychodynamic approach to instruction and therapy session with that?
Yeah, definitely. I guess could everyone hear the question? No. Okay. You know what we're going to do? We're going to let you.
Okay. No, I was wondering, in a patient who has an anxiety disorder, who's now developing a somatoform condition, let's say chronic migraines or fibromyalgia, what's the psychodynamic therapeutic approach to approaching this person?
Okay, you said an adolescent. Young adult. Okay, so the first thing I want to say is that's more complicated than just an anxiety disorder. When someone's really developing a full-blown psychosomatic syndrome, you know, what I can say, we've done some research in a time-limited, twice-weekly, 3-month anxiety-focused psychotherapy. And really, I guess what I would say is certainly you have to start with the symptoms. I just have to say migraines are their own thing. Let me break this question down. The first thing is, if you have someone with psychosomatic symptoms, I think you really want to, first of all, make sure that it is truly psychosomatic and not a medical disorder. There have been studies where they sort of take index diagnosis. This was done at Sinai, an index diagnosis of, say, conversion disorder, and they follow them up a couple years later, and about a third of them have a medical illness that explains their disorder. And of course, the worst thing any of us could ever do for any of our patients is treat a medical illness as though it were a psychiatric problem. I think this happens, you know, patients are difficult to classify. They are rapidly characterized as psychosomatic. That doesn't always mean they are. So if you've got someone like that, like, have a high index of suspicion. If you're really convinced that it's an anxiety disorder, going back to your question, you know, you really want to develop your treatment, or at least what I would recommend. I'm sure other people would recommend different things, but around the symptoms and determining the underlying meaning of the symptoms. And you really want to try to stay focused on that. You know, surely you want to hear about the patient's life and their developmental spot and why they're in a crisis now. But if you're really convinced that it's psychosomatic, the symptoms carry meaning. Psychological meaning, and that's your job, is to figure it out.
Thanks for the terrific talk. I have a question about how childhood trauma plays into these anxiety disorders, and how one might approach psychodynamically in a reparation type of way, or reparative.
That's a very sophisticated question. Okay, did everyone hear the question? Oh, how does childhood trauma play into anxiety disorder symptoms, and how would you approach it dynamically? So the answer to part A is we absolutely know that childhood trauma has a role in the development of anxiety disorders. I mean, almost every day I read something else about this, not just, sort of irresponsible stuff, but real stuff. In fact, we don't totally know the answer, and that's partly because psychiatric research has been so compartmentalized that believe it or not, it was really, in terms of clinical trial literature and interventions research, it was really Charlie Nemiroff and Jim Kosis in the revamp study who decided they'd throw in a childhood trauma scale. And guess what they found? They found, oh my God, all these people really met criteria, or at least reported retrospectively childhood trauma. So in terms of the answer to that, I think it's far more prevalent than we know. I was just reading today in The Lancet, something online about how prepubertal panic disorder occurs more frequently in people who've been sexually assaulted. Well, that's in childhood. Bottom line, we don't know the answer. There is certainly a part to play in this. In terms of trauma, I think we have to be careful because everybody labels everything trauma. I think, probably the simplest way of classifying trauma is the way they do it in the DSM, which is sort of criterion A, just a catastrophic event that would be earth-shattering for anyone. Having someone jump off a roof at your feet, that's, impressive. Being raped or abused or something. I think there's sort of a bracket creep where people say, my mother was unsympathetic, and, that's not trauma. That sucks, but it's not a trauma. So how would we deal with it dynamically? First of all, we certainly want to be aware that it's potentially there. And my experience in working with traumatized kids, they don't always necessarily want to talk about it, and you might not find out about it for a long time. Sometimes any clinician who's worked, certainly with prepubertal kids, has the experience of, you think you know this kid really well, you've been seeing them pretty frequently, or for a while, all of a sudden they say, I've been trying to tell you for the last 5 months that my mother locks me in the closet and hits me. And you're like, excuse me? You don't always know. You have to be aware that this happens. And of course, once you find out, if you're working with a child who's embedded in a family, then of course you have to approach it with a family. So I'm not giving you a dynamic answer, but just sort of a practical answer. I'm sorry, I have to.
Thanks for a very thought-provoking talk. It occurs to me that we have a tremendous amount of information about babies across New York State on the first day of life. They're screened for things like Wilson's disease, glycogen storage disease, an immense number of rare and often devastating illnesses, some of which can be prophylactically addressed if recognized early. Now, what do we know about vulnerability to anxiety? We have stuff like the AGPAR score that's been around longer than I have, I think. We now look at these babies sonographically so that we have some idea, we can get some idea of their movements antepartum. We have amniocentesis on a huge number of patients. We have cord blood that is now collected on a large number of people. what do we really know about vulnerability to anxiety biologically from day one? Because if we understood that better, we might be able to start treating this on day 2. It probably would be worthwhile. There are cultures where certain newborns, the family is routinely visited by a nurse or a social worker who's trained in some of these child-rearing issues. That would be a very good investment if we knew who and where to use them, and if we could measure effectiveness.
Thank you. I have nothing to say. This is all I can say is we don't know. It's minimally anxiety is a polygenic.
Do we have cortisol levels on newborn?
I don't think so. But birth, birth is sort of a trauma. I don't know. It seems like I don't know. That's true. Well, maybe not. I don't know. Yes.
I just wanted to ask, I thought I heard you say that anxiety disorder in children leads to depression in adults. Did I hear that right? How does that work? Did we know?
I've heard many talks on this. What I can tell you is it's a precursor and a link. It's probably linked genetically. There are probably issues with poor self-confidence and feeling incapable and hopeless that then carry over into adulthood. I mean, similarly, I guess, but I don't know the answer. Certainly, if you account for anxiety disorders, Danny Pine did an interesting study in the mid-90s where if he accounted for predisposed or I guess pre-existing anxiety disorder in new onset major depression, it really there's this 2-to-1 or 3-to-2 ratio of major depression in women to men, and it really took away the gender difference in depression distribution. So, I mean, a lot of the anxiety disorders that we see sort of accounts for young girls going on to developing depression, presumably more men drink or buy guns or something. And we don't hear from them as being depressed from any source that we would. The other thing I just would say is that researchers in Pittsburgh have looked across anxiety and mood disorders to see, well, who is it who doesn't get better from our treatments? And they looked at medication treatments, they looked at all different psychotherapies, they looked across disorders, and really the most common factor that accounted for the greatest amount of variance in terms of non-response was adult separation anxiety disorder. So that's like this lurking thing that's sort of popped up that also is a link between anxiety disorders and mood disorders. But they frequently co-occur. The comorbidity is huge, especially in adults.
This was really a terrific talk. The one question I had, you didn't talk anything about guilt. I did something bad, I'm a bad person, I should be punished, or I'm going to be punished. Is that something that you see in your clinic?
Definitely guilt is a common underlying dynamism in anxiety. And certainly I think the way it functions in anxiety, the symptoms are so embarrassing and so unpleasant. It's really embarrassing for kids to have an anxiety disorder. They feel inadequate, incompetent, and I think the symptoms themselves are sort of self-punishment often. They sort of serve as a way of expressing guilt.
And shame.
It's very embarrassing. It's very embarrassing. Sorry. Oh, I know. It's crazy, right? This room has a hex.
So I know that cognitive behavioral approaches are commonly used to treat anxiety disorders in children, but what would be the psychodynamic approach? Or is there one that's kind of comparable?
Absolutely, CBT has been demonstrated to work for kids with anxiety disorders. It's been studied in kids with 3 anxiety disorders: generalized anxiety disorder, separation anxiety disorder, and social anxiety disorder. And it works. It was one large 4-site study, really only one study, and it works acutely about 60% of the time, and then at follow-up more like 40% of kids remain well. So it works. It's great. It's not everything. The dynamic approach, really very few people have been doing research in this area. We've been doing research in this area, but we've never conducted a randomized controlled trial. We've only done open trials in kids. We've done RCTs in adults. So, you know, and basically we've described we've written a manual for kids and adolescents with anxiety disorders using a dynamic, time-limited, symptom-focused dynamic treatment. There's a group in Britain that also has a little open trial. Really, there are no responsible RCTs in this area. I wish there were. And that's not because people don't care. That's because it's really hard to get it funded. Yes.
I think that I missed something, and I would like to know why you had pointed out Charles Darwin as the first introduction to your wonderful presentation here today. And I thought it might be because he's the king of anxiety disorders. It took him 40 years to write his synopsis from his travels, and during that time he had to take baths and water treatments and everything, and it was when he finally published it, his anxieties left him. So I just needed to know why you had presented him.
That's very cute. But they're still mad about it, right? So he should have taken those baths. I put him up there just to emphasize that there are adaptive elements to anxiety. And I just think it's important that we remember that. I think, you know, when you're working with parents of kids who are suffering with anxiety disorders, they tend to feel so bad and guilty that they've imparted this awful problem to their kids. And it continues not just because we're not experts at treating it, but also because elements of this genetic and personality predisposition are adaptive. And I just think it's important to remember that.
Since you brought up Darwin,
Yeah.
I just want to say that attachment is not trying to make mammalian really sort of all through the spectrum of different species. And what I'm working on personally right now is hardwiring. Parents of birds and reptiles can be hardwired. They are hardwired, and we know that. And I think we've somewhat
I wanted to know if you could say a little bit more about not maybe early elementary, what a dynamic treatment would look like for that, and given how much you've talked about attachment and parenting, what work can be done with parents?
Really good question. So first of all, if you're working with an elementary school age kid, you are also perforce working with their parents. You really have to be. The parents, I mean, they're of course responsible for getting the child to your office, but you really can't get the kind of coherent history that you might want from the child. You really want to observe what the parents are doing. And, I would say it's really one of our roles as clinicians is to give parents constructive feedback about how to handle crises that are ongoing that you see. I could give 1,000 examples, but certainly it's very, very important to, and you want to ask, how do you handle sleeping? Or what do you do when she wakes up in the middle of the night and comes into your bed? And what do you do when she has a complete hissy fit in the Museum of Natural History and the entire room comes to a halt? What do you do? I mean, and giving them sort of simple strategies, which is often not getting as agitated as the child, can be really important. They're very different. I think there's a huge piece of what we do in child therapy, child psychiatry, that not enough people write about. I think we all focus on what we're doing with the kid. You started your question with what would a dynamic treatment look like with a kid? It's mostly conducted with play, because that's the language they speak. And, you want to listen to themes, but you also need to have a context about what's been going on and give your little thoughts either in the play or outside of the play. I mean, that's takes years to learn to do it, but that's sort of the modality that we work with kids. And then, kids who are playing will frequently sort of stop playing and bounce from reality to fantasy and back and forth. And that's sort of the way a child therapy works. But work with parents, you're going to pick up themes when you know a kid. And it's very important to give parents simple, constructive feedback because they hear so many things. They're often, especially with anxiety disorder kids, the parents are often quite anxious and they're freaking out. And it's really important to be calm and structured with them and to sort of role model some, talk through some issues. Like, example, the mother of an extremely anxious 6-year-old with panic. She had blonde hair and she came in with dark hair. And I said, "Oh, you have dark hair." The kid was, walking into my office and she said, "Yes, my daughter said, well, isn't brown hair good enough?" The daughter has brown hair. "Isn't brown hair good enough for you, Mommy? Why did you have to dye it?" So, she actually dyed her hair brown for her daughter. Like, that's not an emergency. You don't have to do that. Everything your child says is not a crisis. And there are parents who have tremendous difficulty tolerating the fact that their child is nervous or scared or in distress. This is part of life, and the bigger deal we make of it as parents, the more frightening it is for the kid. So these are things that, it's not that there isn't a signal, but it amplifies this signal,
Teachers as well.
Teachers, absolutely. You want to say something about teachers?
No, just that during the day, the teachers are often in the role that the parents are in the rest of the time. And so if you're working with an anxious child, you'll see their success and adaptation rate vary each year depending often on the teacher that they have and how well that teacher is able to handle anxiety in his or her classroom. And that's more easily markable than the parenting, which is sort of permeates the child's whole life. The teachers come and go, so you can really track the variation.
Fall on my head for finale.
To sort of piggyback off of that, I'm a school psychologist in a high school, and I find like something like the Conners for like ADHD to kind of do a self-report for the teacher and for the parent to kind of help the parent understand if there's a problem that's pervasive like ADHD. I was wondering if there's something for anxiety specific, like a screening tool.
We have screening tools, but by the way, the Conners, very useful, used all the time. I have to say there's tremendous bleeding from sort of disorder to disorder. So teachers, you're a school psychologist, so you're going to be more proficient at the scale. But, if you have an obnoxious child who talks back, they'll do very poorly on the Conners, even if they don't have ADHD. Because they're so aggravating. The teacher is just like, oh. So that's, but the Conners is reliable and valid. The problem, we do have checklists. They're really not designed for people outside the family. So there's, parent and child versions of, I think it would be bad in the school. It's never been used in the school. I'm sorry, you were, oh, I'm sorry. Was someone else back here? No?
I just wonder how you deal with the shy child the first time they come into the office. In other words, my impulse is to help to calm the child and make it feel safe. But is there any particular approach or strategy that you might do, just instinctive?
I think it is instinctive. It depends on the kid's age. It's very different dealing with like a recalcitrant 14-year-old boy who just doesn't want to tell you anything, and it's very embarrassing to be going to a psychiatrist versus like a really frightened 3-year-old where you might, get on the floor, whisper, puppets, the usual litany you would use.
I was just thinking of a case I saw, a 10-year-old boy who was afraid of throwing up all the time and going to sleepaway camp. And I couldn't make any head, he would come in, he didn't really want to play, we would do some card games. The only time it really made headway was when he was with mom and we got out that there was this whole family dynamic that the grandparents the father's parents weren't speaking to the mother and hated it. And it was this. So it wasn't necessarily an anxiety disorder. I mean, I think the mom was anxious, but it was often I think there is this family layer that parents deny, and it takes us a while. You're talking about that the child has had a trauma. Often I think there's a family that's had a trauma or some kind of pain or issue that doesn't come to light, and the child is often acting it out because it's not being spoken about.
I think that's a really excellent point. One thing that I frequently hear from parents is, this is the worst, I'm having an affair, but my son has no idea. Anything that is going on in that house, that child knows. Right. That's the thing. And I always tell parents this, and they say, oh, there's no way. They have no idea we're talking about getting a divorce. They walk in, that's the first thing they say. If they're able to talk about it, your person was going to vomit, so he couldn't speak. But they know all the family secrets, and they also know how dangerous it is to bring it up.
My friend's a school psychologist. He has this group with kids, 5th grade or something, and they're talk about, the kids are talking about, if you want to know whether your mothers are carrying on, check the trunk of a car, see if she has an extra set of clothes there. Those are the kind of
There we go. They know everything.
I just wanted to bring up the issue of the various ways that anxiety can present, because it can look like nervousness. It can also look, as our Barbara was saying, in a classroom, it can look like anger or resistance or acting out. And so sometimes, one of the difficulties in figuring out that the child has a primary anxiety disorder is sifting through the superficial behavior first. And I don't know whether or not you want to talk about how you address that with the families, that they might actually be misunderstanding what they're seeing.
Right. It is often a surprise. I would say it is the less psychologically aware families where it's really a surprise. I've had a number of parents of very young children where the child has a very clear anxiety disorder, where the mother is so highly anxious about separating, all non-verbally. It's the way our patients and their moms act at the door to our office or at the door of a classroom is really, really instructive. That really tells us what it's like to come and go in the house, and interpersonal distance, and how separation is tolerated. And it's not really every family or mom that is aware that she's anxious about separating. I've had patients where the mother's just shocked to hear, first of all, that their child is terrified and maybe they shouldn't be watching scary movies. And that's like news. That's really big news. And, also just the feedback that you seem very frightened of letting her come into my office. Really? I didn't know. So that's important feedback.
Is there data on, if you talk about attachment, if you're 7 years of life, stays at home, is somewhat anxious, she's the mother. Thank you. Is there data in light of attachment theory for the first several years of life, a mother who stays at home, she's somewhat anxious, but she's a mother, or mother's working and there's a wonderful care person, less anxious because she's not the mother. The attachment in terms of the development of a child who may have some predisposition towards anxiety, is there some data that staying at home with your mother is going to be better prognostically in terms of quieting down that tendency to develop anxiety?
There are no data about caregivers versus mothers and attachment.
It's changed tremendously in the last 25 years. A lot of children now with mild anxiety disorders are losing weight, moms are working, and even from a very young age, I think these children are cared for by care people, may have anxiety or not, but they're not the attachment is not as strong as with the mother.
Definitely.
Is it the attachment that helps allay the development of anxiety, or is it the quality of that attachment, is irrespective if it's a mother or a more caring, soothing type of care person?
Look, I think routine caregivers have a huge role to play in a piece of kids' development. I think I would argue that for a mom to be working outside of the home, she's not that separation anxious. She might be separation anxious, but she's able to go to work. There are a lot of people who are far too anxious to trust their child with someone else, or however it's framed. Certainly caregivers play a huge and often mitigating, sometimes the opposite role in anxiety. Yes.
I would like to say something to your question. I can't remember, but there is a little study being done in Switzerland where it's very traditional to have the mothers stay at home rather than work or only work part-time, and sort of promoting the outside of home daycare. And they did a study with children which had issues with anxiety or other sort of not really nurturing family homes, and they saw a positive effect when they were actually been in a daycare. Right. So, yeah.
So that's not surprising, right? The people who raise kids have a huge impact on their lives and their ability to form relationships. That's interesting study.
If there aren't any other questions, I just want to thank Dr. Milrod very much.
What are you studying?
I was once in schizophrenia, and it's mood anxiety disorders. I was actually initially a high school teacher. And I get what you're saying.